Okay, well, welcome to our sports medicine talk tonight. I'm Dr. Barclay. This is Dr. Gillette. I'm going to get us started. I'm going to talk just briefly about 3 topics in sports medicine. Last night, Dr. Gillette actually called me and said if I could keep my comments really brief so that he could have enough time to cover all that he needs to. So I'll try to stick with that. He also volunteered to answer any questions that you guys might have at the end of the talks too. So, well, I just wanted to show some of the teams that I've had the chance to help provide medical coverage for during my fellowship training and during my residency. Mercyhurst Lakers, that was a college that we took care of up in Erie, Pennsylvania. The Erie Bayhawks, that's an NBA G League team. The Trevor Brown High School, I helped cover their football games as a resident down in Phoenix, Arizona. Mercyhurst Prep, that was a high school team in Pennsylvania, as well as the Corey Beavers in Corey, Pennsylvania. So a lot of this talk comes from some insights that I got from my mentor, Dr. Larry, who was a program director up in Pennsylvania. And he always would say that a fit player is better than an injured star. And he had this little picture that he showed us all the time about durability is more important than ability. And so what he's talking about there is that sometimes we have to protect athletes from themselves when they're injured and they want to get back into play from a concussion or from whatever injury they may have had. It becomes the team physician's responsibility to make sure that they're rehabbed and that they're recovered adequately from their injuries in order to safely return to play. So this is a great slide about the importance of a college education. To make it into the professional sports, it's like winning the lottery. If you look up here on the left corner, the number of high school football players, and then if you're lucky enough to be one of the 6.5% of those high school players to become an NCAA football player, and one of the 1.5% of that group to make it to the NFL, you'll be lucky to get 3 years out of it. At a minimum salary, you won't make enough to live on for the rest of your life. What's going to provide for you and your family after football is over? Your college education. So that's a great slide to remind some of the young athletes of the importance of continuing their education. So one of the topics I'm going to start with addressing is concussion. And so there's some great resources out there. One of the resources that I refer my patients to when they come in with their parents for a sports pre-participation evaluation is the CDC website Heads Up program. And there's a lot of great information on there about for parents, coaches, and athletes. And so I encourage them to take a look at that, and I encourage you to take a look at that website later and gain some further information on concussion and what are the signs and symptoms and how is it managed. So that's one of the things I addressed during the pre-participation evaluation. Also, we do concussion evaluation and management, and I use the SCAT-5 assessment tool to help monitor symptoms and progression and help patients back through the return to play protocol. So some of the key issues with concussions is that not all concussions get diagnosed. So there's more concussions that happen than we know about. And that's part of that is because they just go unreported, some that we don't recognize. But it's helpful if the physician is there to see and recognize the event and help the trainers diagnose appropriately what's a concussion or what's just head trauma. Children and females suffer more from concussions and have a harder time recovering. Multiple concussions have consequences. Once an athlete has had more than one concussion, they are more likely to get further concussions. It's easier to have a concussion, and they have a harder time recovering from their concussion. So early return to play can be catastrophic. They can have second impact syndrome or have to start over from square one if they return to play too soon and have a recurrence of symptoms. Also, long-term deficits can result from repetitive head injury. So some high school stats, some of the sports that are the key or the biggest culprits for concussion is football up at the top of the list, ice hockey. Some of the big contact sports are going to see more concussions. Soccer, athletes like to use their heads as a tool, which it wasn't designed for. Lacrosse athletes have concussions. Wrestlers, basketball, softball, field hockey. Cheerleading isn't as safe as you might think. We see a lot of cheerleaders who get dumped on their heads or fall on their tailbone, have injuries that way. So then volleyball players, baseball, and gymnastics. So as I mentioned, there is a specific return to play progression, return to learn and return to play. It's a stepwise progression that team physicians and athletic trainers can help guide athletes safely back to return to play. So level 1 is physical and cognitive rest, no physical activity or school, no reading, computers, video games, or text messaging. But recently, there's been some data that actually getting some light subthreshold activity early on can actually be beneficial and help athletes return or recover from their symptoms a little bit sooner. So we encourage that, and as long as it doesn't exacerbate symptoms, it can be a good thing and help speed up the recovery process. So level 2 consists of light aerobic exercise such as walking or stationary cycling, no resistance training at that point, abbreviated school attendance, and they can start reading about 20% of their normal volume, and they're allowed to watch some TV. Level 3, if they can pass level 2 without any recurrence of symptoms, then they can advance to level 3 to sport-specific exercises, still no resistance training. They can increase their reading volume to about 40% of the normal amount, and still no video games. Level 4 is non-contact practice. Resistance training, they can gradually start to incorporate, upping the reading to about 60% and still holding out on the video games. Level 5 is full contact practice, 80% of normal reading, and finally some video games are allowed. And then level 6 is full return to competition and school activities. If at any point the athlete has any recurrence of symptoms, then they drop back to the previous level where they didn't have symptoms until they can advance again to the next level. So, as I had mentioned, sometimes there are head injuries that aren't concussion. Not every athlete who gets suffers some head trauma has a concussion. But it's important to not return, even if we don't think they have a concussion, return them to their activity. Specifically in the case of the very, very young athlete, female athletes, an athlete who had a second ding in a contest, an athlete who has just recovered recently from a concussion. If they have some head trauma, we want to be a little bit more careful about their head injuries. And also reluctance to participate. So if there's an athlete who has lost that eye of the tiger, then they're not ready to go back into play. During my fellowship, the college quarterback took several sacks and was getting thrown around quite a bit, and the team was losing, and we evaluated him at halftime. He didn't quite meet criteria for a concussion. He passed all his neurological evaluation, but we could see that he did not have the desire to go back into that game, and so we went ahead and held him back. And then, within a few days of the next week, he had that eye of the tiger back, and so we were able to clear him and get him back in the following week. All right, so speaking of common sense, this is a real important example here regarding our young athletes. These are two 13-year-old male athletes. This athlete on the right is going to concuss the one on the left. And so we need to make sure that our athletes have an equal playing field. If this was my son here on the right, he wouldn't be playing on the football field. he would be in wrestling or track and field or playing on the golf team. Okay, so that's an important one to remember, that we need to protect our athletes and not put them in situations where they can have injury. So not all concussions are alike. Each of them are unique and to the athlete, and there can be different components of a concussion. They can be cognitive, vestibular, oculomotor, affective, migrainous, or they can be cervicogenic. And so that's part of the evaluation process in the office. When we see, for example, an athlete on the field and we diagnose them with a concussion, we can further evaluate their symptoms in the office and manage the specific components of that concussion, or refer them to different specialists who can help us with different kinds of rehab and training to help them recover a little bit quicker from their concussion. So a few more stats. The vast majority of athletes or patients who experience a concussion, they resolve rather quickly in about a week or two, but there is a small majority who persist for a month or even longer, and those are the ones that need a little extra help. 75% of concussions come from contact with another player. A very lower percentage experience loss of consciousness, so not all concussions require loss of consciousness. And interestingly, about 35% of patients before they had a concussion have headaches, but about 95% have headaches afterwards. All right, so that wraps it up with the concussion. I'm going to transition to the number one problem in sports medicine right now, and that's actually mental health. This is the NCAA director here, and he actually implemented a new campaign called Mind, Body, and Sport to help athletes who are struggling with their mental health. Some of the current trends of mental health in college students might surprise you. About 1 in 2 has been in counseling, 1 in 3 has taken a psychiatric medication, 1 in 4 has self-injured, 1 in 3 has seriously considered suicide, 1 in 10 has been hospitalized for psychiatric reasons, nearly 1 in 10 has made a suicide attempt, 1 in 5 has experienced sexual assault, 1 in 3 has experienced harassment or abuse, and 1 in 3 has experienced a traumatic event. So some red flags that we can watch out for are a prolonged recovery from illnesses or injuries, purposeful underreporting or overreporting of symptoms, missed appointments, poor classroom performance, anger mismanagement, irritability, and sleep disturbance. Some emergencies that would need to be referred or managed in the inpatient setting or in the hospital would be active suicidal or homicidal ideations, sexual assault, physical assault, acute psychosis or paranoia, highly agitated or threatening behavior, acute delirium or confusion, acute intoxication or drug overdose. So as I mentioned, the pre-participation evaluation, that's another important opportunity where a physician can screen patients for mental health problems. And at our clinic, we try to screen every patient that comes in with the screening tool that we use. And that's something that we can discuss with the athlete and their parents at that time if they do have a positive screening test. Athletic trainers are another great resource to help recognize the warning signs for mental health problems and help refer them to the proper medical provider. But as mentioned, imminent threats, such as the red flag warning signs, must be evaluated and treated in the emergent setting in the hospital. So some other behaviors to watch out for that can reflect psychological concerns. So changes in eating and sleeping habits, weight changes, substance abuse, gambling issues, social withdrawal, decreased interest, talking about death or dying, loss of emotion, problems concentrating or focusing, frequent complaints, headaches, unexplained wounds or deliberate self-harm, irritability, anger, irresponsibility, lying, legal problems, negative self-talk, mood swings, excessive worry, shaking or trembling, gastrointestinal complaints, and overuse injuries. So one of the ideas that my mentor shared with me is something called the Wellness 5. And so these are 5 different components of our overall health and wellness that if we're not taking care of each one of these aspects of our health can cause our overall health and wellness to diminish. So we need to take care and make sure that we're exercising regularly, getting adequate sleep, taking care of our nutrition, eating healthy and hydrating adequately, taking care of our mental health, and avoiding substance abuse. Some other simple things that we can do: lose some weight, stand up straight, speed up your gait, don't fill your plate, sleep for 8, talk to your mate. Those are things that can help improve our mental state. All right, so I'm going to transition to a little bit to my last topic. That's going to be ACL prevention programs. That's another thing that I try to address with athletes when they come into the office for their pre-participation physical. So as a team physician standing on the sideline, your eyes are going to be glued to this player here and cringing every time they have contact with another athlete with 2 braces and knee taped up. This is an athlete that looks like they're going to go down and require an ACL repair. And when Dr. Gillette sees a patient like this, he starts to get excited and gets his scalpel ready to cut. So these are some of the types of exercises that we encourage an athlete to incorporate in their regimen to help strengthen their core, plyometrics, and different jump training to help strengthen the supportive structures to the knee to help reduce and avoid ACL injury. Up here on the right, you see an athlete doing some resistance band exercise, monster walks. These athletes over here are doing some east-west work to help with the adductor and abductor muscles. We've got some pool therapy here, balance training, and some box jumps down here. So some of the basic principles in the ACL prevention programs, they're 6 to 8 week programs incorporated 2 or 3 times per week. But once the program's completed, they have to perform maintenance exercise throughout the year to maintain. The exercises mainly involve jump training, plyometrics, agilities, balance, postural stability, core strengthening and conditioning. And a great idea would, if these prevention programs would be incorporated in the postoperative ACL rehab and return to play program. So one of those specific programs is called the PEP program, which stands for Prevent Injury, Enhance Performance, and that was developed in Santa Monica, California. It's a 20-minute training session that replaces the traditional warm-up routine. It was developed by a whole team of physicians, physical therapists, athletic trainers, and coaches. And the main focus of that is to educate athletes on how to move and prevent or avoid injury. Some of the other goals are avoid vulnerable positions, increase their flexibility, increase strength, include a plyometric exercise, and increase proprioception or balance through agilities. So these are some of the specific exercises for injury avoidance. The athletes will do jumping barriers, backward running, shuttle runs, and some of the strengthening exercises are walking lunges and toe raises. And then wobble board, side hops, 1- and 2-legged hops for plyometrics, and then some diagonal runs, shuttle runs, and bounding for agility training. And so those are just some of the things that I try to implement with my patients when they come in. Screen them for mental health, that if they do have a positive test or have concerns there, give them the help that they need or get them to the appropriate medical provider. Concussion counseling. I encourage you all to take some time to look at the Heads Up program on the CDC website and learn a little bit more about that. And then ACL prevention programs. If I can keep as many athletes away from Dr. Gillette, I've done my job. He does a great job, and you'll see that. But so those are some of the things that I like to do and try to incorporate in my practice. And so I appreciate your attention, and I'll turn the time over to Dr. Gillette.
Okay, so I just really like these two websites. You get really good information that's accurate and, you know, looked through and not get too off the beaten path with kind of these topics. Okay, as I mentioned, shoulder, hip, knee, and ankle, kind of the most common things, but things that can go either way, surgical versus conservative management. So starting with the shoulder, just a little quick anatomy tour. You okay if you still got me in the picture if I come over here? So the shoulder is a very interesting joint. Kind of think of it as a golf ball on a tee, but what's important is the labrum. So the labrum, it goes around the socket and enhances and makes the socket bigger, makes it stable. So what you hear about Bankart lesion or Bankart tears is what happens when an athlete or someone dislocates and they go out the front. They tear the junction between the cartilage and the labrum of the shoulder joint. It makes the shoulder unstable. Extremely common out the front, more common than out the back. As you can see, wrestling is a good example of this. But any contact sport. So but the age when you first dislocate is the most important prognostic factor, whether you're going to require surgery or keep having recurrent subluxations and or dislocations. Going out the back in an actual incident tends to happen more seizures or electrocution. Football linemen who are constantly getting hit on the line, it's going to keep pushing back, and so they get posterior instability, and actually more common in just young females generally. Hypermobility syndrome, there's a whole scale for this, and some of you are going to go home and practice these. At night, I'm sure, like, am I hypermobile? But if you can touch your thumb to your wrist, your pinky finger goes back past 90 degrees, I'm not hypermobile, so I can't even do that. Your elbow hyperextends and you can touch the ground with your feet flat, then you may have hypermobility syndrome, which predisposes you to certain instabilities within the shoulder and with your kneecaps and other places. So just to show you what happens with dislocations, the humerus goes right out the front. And if anyone's ever had one or knows someone that's had one, a lot of times when it's dislocated or after even when it's being put back in, they will have numbness and tingling and down into their fingers or into their hand, or the arm will feel dead. Reason why is because look at all those nerves that are tracking right through that armpit down into the arm. So lots of people in the worst cases can actually have a palsy of those nerves for 48 hours. And again, what's allowing it to release off is a tear between the labrum and the glenoid. So just a common thing that gets talked about a lot. Dislocation of the shoulder versus shoulder separation. And fundamentally, a dislocation is where the humerus is out of the socket, okay? Whereas a shoulder separation is a dislocation of the clavicle where it attaches to the scapula bone. And so that's usually happens a football player diving into the ground and popping that shoulder joint, or a bicyclist, very common. Whereas dislocation, is usually when somebody gets kind of torqued into a weird position, generally this position. What's funny is Seven Peaks Resort is a really good example of how to distinguish these two. The free fall, or what was a skyscraper at one point, is what a shoulder dislocation looks like. Because sometimes, if you haven't seen one or you don't know what it looks like, whereas this is more the jagged edge, it has a couple of bumps as it comes down. Person with shoulder dislocation will not want to move the shoulder joint at all. It'll be kind of stuck like this. And the reason why is because it truly is stuck underneath that socket. If you remember Love, he got pulled on in a game and he dislocated on national television, and that's what his looked like, and he ran off the court there. The other thing can happen when it gets stuck is the head goes out and gets stuck. It can create a little, basically, defect as it sits and catches underneath. This is an MRI showing, again, when the head goes out the front, the back of the humeral head gets swollen and creates a little defect. Sometimes it's big enough you can actually see it on X-ray. And that gets to be more of a surgical problem. We have to do things a little bit differently in surgery to fix that problem. If you ever want to know how to reduce one of these, the simplest way and kind of big picture concept, and there's a 1,000 ways to do it, but is to relax the patient and to put traction on the arm, to fatigue the muscles, and then usually it'll slide back in. My favorite, and again, if you want to act like a hero sometime, if someone's ever dislocated, just have them lay on a table or a surface and just hang their arm off and just pull on their arm down. And that's it. The most gentle, easiest way to get a shoulder back in place. And you'll be a hero. You'll love it. Conservative management. So a lot of times this will happen mid-sport, right? So I had multiple of these recently. A female high school, basketball player. It's playoff season, dislocates. What are you going to do? You fix it right then? And it depends. Every person's a little bit different. But generally, if it's a first-time dislocation, you can rehab them, and then you may need to put them in this brace called a Soli brace that basically just keeps them from getting into this position. There's lots of ways you can dislocate, but it's kind of the best thing you can do if it's mid-season, and then just fix them after the season, and then just do some physical therapy and give them a little bit of rest. Now, here's this graph I was talking about. So look at how high, if you dislocate between the ages of 10 to 20, 90% chance you're going to redislocate again and have multiple recurrent dislocations. Whereas if someone who's 50 dislocates for the first time, we don't even fix those. We just put them in sling for 4 to 5 weeks, get out of the sling, start moving the arm, and they won't dislocate again. Because generally as we get older, we get stiffer. And that's why young athletes in that high school phase are really vulnerable. It can get a little more complicated. So not only can you just tear the labrum, you actually can fracture the glenoid, or that socket. And when this happens, you can do kind of a combination arthroscopic surgery, reduce the fragment, and then put a screw into that socket to hold that in place. It's called a bony Bankart. This is just your standard regular Bankart lesion. You see the labrum here, the socket down here, and that is all hemorrhagic and torn off. And then we basically put anchors along the row, and we gather that tissue and we tighten up the glenohumeral inferior ligament. All right, so that's shoulder. So let's talk about hips for a second. Again, lots of different types of kind of non-operative things, from hip pointers, avulsion fractures up the pelvis, tendinitis, hamstring, really common. But what I want to kind of really talk about is terming it femoral acetabular impingement or labral tears. Now, there are some people who are predisposed to getting femoral acetabular impingement and labral tears. And what femoral acetabular impingement is the femur and the acetabulum. Acetabulum is the socket. So in a similar way, kind of to the shoulder, the hip socket is similar to the shoulder of the lower extremity. You have a labrum that goes around the joint over here, same as the one but the hip is more constrained. It's a tighter joint. So this labrum's right here. And what can happen in impingement is people get a bump that sits right at the junction from the cartilage surface. And so as you bring that up, it's going to pinch into the socket. And what's in between is the labrum. The labrum is what's left in between. So if you have this, and as you sit or do certain activities, that hip comes up, the labrum is caught in between, and then it will tear. There's different types. This is the cam impingement, or versus a pincer impingement, where something's coming off the socket. And some people with deep sockets have that problem. People with femoral acetabular impingement have a real difficult time internally rotating, because that's when the bump is coming in contact with the socket. And so if you put someone on a table, and what we're trying to do is actually internally rotate this hip right here, and it won't move, it just stays straight. Whereas they have good external rotation. And especially if some people try to squat, but keep your legs straight, some people can't do it, they have to go out. That's for that bump to avoid hitting into the socket. If you get that, generally, hip socket pain kind of hurts more in the groin, and some people describe it as like a C shape or C pattern around. So if it hurts right here, and and I've seen this in clinic, it hurts right here and they grab it, that can be a sign of this problem. So what do you do to fix this? Well, if it's mild and the labral tear is not that bad, you can start with a steroid shot and try to rehab it. If the bump's really big, that's a structural or mechanical problem. So that usually needs to be fixed. And what you do is with a hip scope, you take a burr and you basically shave down, and this has been shaved, that bump, so that as they bring their hip up, it's no longer bumping into the labrum causing tearing. This is a labral repair, and again you can see the labrum as it comes around and nice little sutures holding that in place with suture anchors that go into the bone. So that's your kind of standard hip arthroscopy for femoral acetabular impingement. All right, so the knee gets, the hip is just kind of the ball and joint. The knee gets really complex because there's three main structures or things we're thinking about as topics with any type of knee injury. And that is these three things. The ligaments, which include the ACL, PCL, MCL, LCL, 4 big ligaments. The meniscus, which I'll go into detail a little bit more, which is the shock absorber of the knee, and then the actual cartilage itself. So starting with the meniscus. The meniscus are these C-shaped structures on the top of the tibia, and they are truly the shock absorbers of the knee. They are a type of cartilage. People always say, I had some cartilage cleaned out, and I never know what they mean by that. So I asked, like, was it your articular cartilage? Was it the part that you walk on, or was it the meniscus? Meniscus is a fibrocartilage. It is a type of cartilage, but it's not the smooth bearing surface that we walk on. That's the hyaline cartilage. It's a different type of cartilage. And it's not as strong, whereas the fibrocartilage is collagenous and is more fibrous, and therefore it can have more shock absorption. And then it does give a little bit of some stability to the knee, but it's mostly the shock absorber. Now, types of meniscus tears that happen, young kids tend to get traumatic meniscus tears, and that usually can be associated with ACL tears or other instability type situations. And what happens is when ACL tears, for instance, it can grab that meniscus and cause it to tear. And there's lots of different types of tears. Let's see, this moves if I do it. Whereas older patients, usually over 40, what happens to the meniscus over time is it becomes degenerative. And we'll see this in surgery, even just last week. As you trim out this meniscus tear, you'll see this yellowish kind of fatty material in the middle of the meniscus. And it's just think of it as like a rotten apple core. As the inside of that meniscus gets degenerative, well, then it makes it prone to tearing. So that just even, a twist in the kitchen or even a bad fall can cause that meniscus to tear. Or even just wear and tear over time. And again, it's worse when arthritis steps in. As arthritis steps in, it puts more pressure on the meniscus, causing it to tear. And these are usually kind of complex tears. They go in different directions. This just show you how you can tear the meniscus. It can be a radial, a flap, or what's called a parrot beak type tear. Horizontal, which is like a horizontal cleavage tear, which goes in this plane, or this kind of complex tear, which a lot of your arthritic meniscus tears are going to be the complex pattern. This just shows a simple partial medial meniscectomy, kind of the simplest procedure we do. You just take a little biter and you just trim that little flap, because that flap's catching and causing pain in people when they come into the office. But it can be as bad as this. So this is a displaced bucket handle tear where the whole meniscus pulled off from the sidewall, flipped over and into the middle of the knee. And the way it can happen is if it tears way out here, this whole thing flips upside down and into the notch of the knee. And it seems like we had a rash of these lately, but they'll come in and they cannot extend their knee straight. And so any athlete that we see that cannot extend their knee and cannot get straight, even especially if it's been a few days and the swelling's down, they get an MRI to look for displaced bucket handle meniscus tear. To fix these, if they're fixable, basically we just fire these sutures through and reattach it back to the capsule of the joint. And then problem is with meniscus repairs, it's 6 weeks usually, non-weight bearing for the athlete. So it slows down their recovery, especially if they had an ACL reconstruction at the same time. Okay, so ACL surgery. This is kind of a really, really common thing. Also, big time risk for some of these athletes, especially in female soccer and football, probably our two highest. ACL is the primary stabilizer of the knee. It's this thing right here. This is the inside of the knee, this is the outside of the knee. And the ACL makes this approach between the two bones, keeping both rotationally stable the knee, but also in this position. Again, 3 to 9 times higher rate in females. And this is largely due to some probably more likely, the most important probably, being, just to have a little bit softer collagen in general, but then biomechanically, which Dr. Barlcay alluded to. Female athletes generally, when they do a squat, their knees kind of go in more, and it's a neuromuscular genetic thing that they do. And so what he was showing with all these exercise testing is that we have to really strengthen. Oh, hey, the video worked. That's exciting. But notice how the knee shifts in with every step. It kind of shifts in. Well, that was a pleasant surprise. Except now I can't stop it or advance. Okay, let's try this. This means this might work too. So watch this jump. And Casey said the video wouldn't work. Wow. So look at that knee cut in. So that's a really, really important thing to look at. And the reason why it's cutting in like this is actually starts at the hip abductor muscles. And so what Dr. Barlcay showed and what I would show as well is you start with basically a couple of different things. Clamshells, though, is what this one's called, where again you're pulling the legs apart to strengthen these hip abductor muscles up into the glute muscles. And then also just doing some side leg raises, monster walks where you walk with an elastic band and pull out. And then when you do squats, having the elastic band around the knees, again, to prevent this, you have to put pressure out here so that, again, it's stabilizing and strengthening those abductor muscles. So that's a really important part of the prevention program, and that we're really trying to get out there in this community, actually. So now let's talk about when you do actually tear it. So it is really important to reconstruct these. There was a big article that was in the Lancet that said, oh, you don't have to fix ACL tears because they do as good as people that are not fixed, or the fixed ones fixed do as well as the ones that aren't fixed. So it's really not true as you dial down into that study. The biggest thing is, and we see this every week, someone that has an ACL tear kind of didn't know it, then had a second injury, and now they have a huge meniscus tear and an ACL tear, whereas before they just had an ACL tear. And so what the ACL, what happens is if you get a little instability in the knee, there's a little more, you can get a little bit more of a run, and it will grab that meniscus and it will tear it and do a bigger tear. So very important to keep your knee nice and stable and do the ACL reconstruction if you need it. There are some instances if you're older and more sedentary or just, like over 60, then we'll consider maybe a trial without fixing ACL and see how you do. But generally, anyone younger almost always should fix it. You'll see this on TV. This is the Lockman exam. You ever see them kind of filling the knee? That's exactly what they're doing. They're testing for the ACL stability on the field. That's called the Lockman test. And then just to talk quickly about the different types of ACL reconstructions that you can do. Bone, patellar tendon, bone. Basically, you take the central third of the patellar tendon with the bone blocks and then put those into the place of the old ACL. It's really good for high demand athletes because of the excellent fixation. You get bone to bone integration rather than tissue to bone. Very durable and has a lot of long-term data. The problem is some athletes, or especially if they're wrestlers, on their knees a lot, people can get anterior knee pain and have some pain with kneeling. So reserve that really mostly for football players and soccer players in general. Now, the semitendinosus and gracilis graft basically steals 2 of the 3 hamstrings that sit on the inner side of the knee, and then you take them and fold them over, and then basically hold it in place with a button on one side, and then some type of device on this side, interference device or a screw. Again, you don't have that anterior knee pain. Do get a little bit of hamstring weakness. Most people don't feel a subjective weakness. However, if you test them on a computer or some type of device, it will note about maybe 15% hamstring weakness in flexion. And again, if we get a stable knee, we can get about 90-95% return to sport. So it's a really successful surgery. Okay, now to the articular cartilage. Again, in young athletes, sometimes we'll see these big chunks of cartilage taken out, and we can usually, if there's bone on the back side of it, put it back into place with little small absorbable screws or other types of devices and get that articular cartilage back in place. Not going to really talk about degenerative arthritis, but arthritis in general is once this smooth surface starts turning into a rough surface and starts flaking off over time, that's your degenerative arthritis. And by fixing the cartilage defects that occur in sports when they're younger, hopefully we can prevent that at some degree. Okay, and then a couple things just on ankle injuries, extremely common things. Again, there's a lot of tendonitis and plantar fasciitis and things, but it's these two things at the bottom, ankle sprains and cartilage defects of the talus and the ankle joint, that we have to make a surgical versus non-surgical decision on. Your general ankle sprain is a tearing or stretching of the anterior talofibular ligament here and or the calcaneofibular ligament here. So these two structures right there. And again, there's varying degrees of how these tear and how severe it is. In general, majority of ankle sprains can be treated conservatively, especially if it's a first time. You get a lot of swelling, but may take anywhere from 2 to 6 weeks for these to heal. You can boot it, splint it, cast it. Once you get all that acute swelling out of the ankle and it's starting to feel better, real important to do an ankle strengthening and balance program, and then gradual return to sports. Majority of these, of course, can be treated conservatively. Where it gets tricky is the multiple recurrent ankle sprain. And you have to ensure that there's not a structural issue. There's some, you saw in the old slide, it said tarsal coalition. So a lot of little young kids will keep coming in, yeah, she sprains her ankle all the time. Well, we can get one x-ray view and see if there's two bones that accidentally remained fused in development and didn't separate like they should, which sets them up for ankle sprains. And you actually fix the bone problem and the ankle sprains get better. Or it could just be your standard multiple recurrent ankle sprains or instability. And what you do is you take x-rays and you look at the parallelness of these two joint surfaces. If they're divergent, and this is under a stress view, and this is under a stress view, then we know that the ligament is incompetent. And those are the ones that you would actually fix. So, and then lastly, this special lesion of the talus called osteochondral lesion of the talus can happen with ankle sprains, or it can just happen from an ankle injury. But basically, you get a cartilage defect in the talus, which is this bone right here, inside the ankle joint, that can usually be treated with an ankle arthroscopy and either doing microfracture, or there's some other techniques of adding cartilage grafts to these holes that can occur over time. But really common with the multiply recurrent ankle sprain patient. And I believe that's it. Just for fun, I like this picture because it reminds me of my roots, also reminds me of my family. That's my son Mazer, and also reminds me that the best interest of the patient is the only interest to be considered. And hopefully that's what you can feel from Dr. Barclay and I as we take care of people, is that we really try to get people better for their own interests. So thanks for coming. Appreciate it. And yeah, we'll hang out around a little bit after if anyone has specific questions and can answer this for you.